Welcome to this Step 2 clinical knowledge review on seizures and epilepsy test-taking strategies. This video is brought to you by Roadmap to Residency. We are going to break down the most common question patterns you will see on your board exam for seizures and epilepsy and teach you strategies to pick the right answer quickly and confidently. Remember, the goal here is not to re-teach the entire topic, but to help you recognize the patterns and apply test-taking strategies. Make sure you have reviewed the neurology sections of first aid and your question bank before or alongside this video. Here is what we are going to cover today. First, we will learn how to recognize high-yield question stems for seizures and epilepsy. Second, we will apply specific strategies for questions about First Seizure Workup, status epilepticus management, and antiepileptic drug selection. And third, we will master the next best step question format for evaluating seizures, managing acute events, and working up breakthrough seizures. This video assumes you have some baseline knowledge from your review resources. We are here to sharpen your test-taking approach. Let us start with the most fundamental distinction the boards will test: provoked versus unprovoked seizures. This is your first decision point in any seizure question stem. A provoked seizure has an identifiable trigger. Look for buzzwords like alcohol withdrawal, electrolyte abnormality, hypoglycemia, medication toxicity, or acute head injury. When you see these, the answer is almost always to correct the underlying cause, not to start an antiepileptic drug. On the other side, an unprovoked seizure has no identifiable trigger. The question will describe a patient with no obvious metabolic derangement, no recent trauma, and no toxic exposure. These patients need workup with brain imaging and electroencephalogram to assess recurrence risk. This distinction drives treatment decisions, and the boards test it directly. Now let us talk about status epilepticus, which is one of the highest yield emergency topics for Step 2. The definition you need to know is continuous seizure activity lasting 5 or more minutes, or recurrent seizures without regaining consciousness between episodes. The board question will always test whether you know the correct sequence. Step 1 is always airway, breathing, circulation, and give oxygen. Step 2 is intravenous benzodiazepines. Lorazepam is the most commonly tested first-line agent. If benzodiazepines fail, you escalate to a second-line agent like fosphenytoin, Levetiracetam, or Valproate. If seizures continue after 2 medication classes, this is called refractory status epilepticus, and the patient needs to go to the intensive care unit for continuous infusions and continuous electroencephalogram monitoring. Never skip the benzodiazepine step. That is the most common trap on board questions. Let us review the 3 classic question stem patterns you will encounter. The first seizure stem will present a young adult with a witnessed generalized tonic-clonic event, postictal confusion, no prior history. The key is that the question asks for next step in evaluation, and the answer is brain imaging and electroencephalogram, not starting medications. The status epilepticus stem will show you a patient actively seizing beyond 5 minutes. The answer is always benzodiazepines first. Do not be distracted by options to load other antiepileptics before giving a benzodiazepine. The breakthrough seizure stem will present a patient already on an antiepileptic who has a new seizure. The answer is to check medication adherence and drug levels before making any changes to the regimen. Recognize these patterns and you will answer these questions efficiently. Let us work through our first practice question together. Read this carefully. A 26-year-old woman presents after a witnessed generalized tonic-clonic seizure at work. It lasted about 90 seconds. She has no prior seizure history and takes no medications. On arrival, she is drowsy but oriented and her neurological exam is non-focal. Labs are normal. The question asks for the most appropriate next step. Take a moment to think about what pattern this fits before looking at the answer choices. Let us walk through this one step by step. Step 1. Spot the pattern. This is a young adult with a first-time unprovoked seizure. No obvious trigger, normal labs, non-focal exam. Step 2. Apply the rule. After a first unprovoked seizure, the board rule is to obtain brain imaging, preferably magnetic resonance imaging, and an electroencephalogram before starting treatment. Not every first seizure requires lifelong anti-epileptic therapy. Step 3. Eliminate wrong answers. Option A, starting Levetiracetam, is premature because you have not completed the workup yet. Option C, lumbar puncture, is only needed if you suspect meningitis or encephalitis, which this stem does not suggest. Option D, Discharge with follow-up only is insufficient because you need imaging and an electroencephalogram. The correct answer is B, brain magnetic resonance imaging and electroencephalogram. Now let us try a status epilepticus question. Read the stem carefully. A 45-year-old man with known epilepsy is brought in by paramedics with continuous generalized tonic-clonic seizure activity for 8 minutes. Intravenous access is established. His heart rate is elevated, blood pressure is high, and oxygen saturation is slightly low. The question asks what to do immediately. Think about the algorithm we just reviewed and identify where this patient falls in the sequence. Let us break this down. Read the question carefully. The patient has been seizing for 8 minutes, which meets the definition of status epilepticus. He has intravenous access. The vital sign abnormalities, the elevated heart rate and blood pressure, are expected during active seizure activity, so do not get distracted by those. Now, why do benzodiazepines come first? Intravenous lorazepam is always the first-line treatment for status epilepticus. Fosphenytoin is the second-line agent, given only after benzodiazepines fail. You do not skip ahead. Getting a computed tomography scan during active seizure activity is inappropriate because you need to stop the seizure first. An intubation is premature because you have not tried pharmacologic treatment yet. The correct answer is C, administer intravenous lorazepam. Antiepileptic drug selection is a heavily tested area, so let us break down the key pairings you need to know. Levetiracetam and lamotrigine are first line for focal seizures. Valproate is the drug of choice for generalized epilepsy, especially juvenile myoclonic epilepsy. Ethosuximide is the classic first-line drug for childhood absent seizures. Now here is a critical point. Valproate is teratogenic and is contraindicated in women of childbearing age who may become pregnant, so lamotrigine or levetiracetam would be preferred in that population. For side effects, carbamazepine causes Stevens-Johnson syndrome and requires monitoring of blood counts. Valproate causes hepatotoxicity and pancreatitis. Phenytoin causes gingival hyperplasia and follows zero-order kinetics, meaning small dose changes cause big changes in drug levels. Lamotrigine can also cause Stevens-Johnson syndrome if the dose is increased too quickly. The boards love testing these side effect profiles, so make sure you know them cold. Here is a drug selection question for you. A 14-year-old girl has brief staring spells lasting 5 to 10 seconds, happening several times a day at school. She is unresponsive during the episodes with eyelid fluttering and returns to normal immediately afterward. Her electroencephalogram shows generalized 3 Hz spike and wave discharges. The question asks for the best first-line treatment. Think about what type of seizure this is and which drug matches. Let us walk through this answer. First, spot the classic pattern. This is a teenage girl with brief staring spells, immediate return to baseline, eyelid fluttering, and the electroencephalogram shows 3 Hz spike and wave discharges. This is the textbook presentation of childhood absence epilepsy. That electroencephalogram finding is pathognomonic. Now know the key distinction. Ethosuximide is the first-line treatment for absent seizures, when generalized tonic-clonic seizures are not also present. Here is the board trap. Carbamazepine and phenytoin can actually worsen absent seizures. This is a classic wrong answer that the test writers love to include. Levetiracetam is sometimes used for absent seizures, but it is not the classic first-line board answer. The correct answer is C, ethosuximide. Here is an important test-taking pearl about breakthrough seizures. When a patient who is already on an anti-epileptic medication presents with a new seizure, the boards are testing whether you take the systematic approach or jump to changing medications. The correct first step is always to check medication adherence and serum drug levels. Patients often miss doses or have subtherapeutic levels for various reasons. Next, look for new triggers. Ask about sleep deprivation, recent illness, new medications, or alcohol use. Certain drugs are known to lower the seizure threshold. Fluoroquinolone antibiotics, tramadol, and bupropion are the most commonly tested ones. Only after you have confirmed the patient is adherent and there are no new triggers should you consider adjusting the dose or adding a second agent. The boards are specifically testing whether you check the basics first or react by immediately changing the drug regimen. That wraps up our review of seizures and epilepsy test-taking strategies for Step 2. To review, remember the provoked versus unprovoked distinction for first seizure questions. Know the status Epilepticus Algorithm cold with benzodiazepines always first. Learn the Antiepileptic Drug condition pairings and their side effects, and always check adherence and drug levels for breakthrough seizures before making changes. Review the neurology chapters in First Aid and your question bank for the detailed pharmacology and classification tables. Visit www.roadmap2residency.com for expert tutors and residency advisors who can help you with board preparation and match strategy. Make sure to like and subscribe for more board review content. Good luck on your exam.